Good morning, everybody, and welcome to this Mental Health Improvement System Support Team programme of support for elective recovery. My name's Paul Hopley, and I'm the Head of Mental Health for System Improvement, NHS England. I first just wanted to thank you all for taking the time and interest to hear more about our programme today. If people just want to use the question and answers just to introduce themselves and just put who you are, where you're from, and if throughout the presentation, if you want to just have any questions, we have got members of the team monitoring that, and we'll do our best to answer those as we go through, but hopefully we'll have some time at the end of the session today as well. So next slide, please. So just want to back to that. So just to introduce the team a bit, if that's okay, the Mental Health Improvement System Support Team, we're a small expert quality improvement team, and we're comprised of senior managers and professional registrants from a diverse background, and we've got experience in delivering NHS improvements in population health, quality of care, value for money in mental health care. And on average, our team, each member of our team has got over 18 years experience working in the NHS. Next slide, please. So today, I just want to introduce at a high level our resources for supporting elective recovery and mental health, and that the implementation support that's available to you in your regions or your you as a provider. Each member of the team will briefly introduce their individual webinar module and how they will be structured. This will be in group work orientated format with opportunities to develop collaborative networks, and we want to sort of really encourage people to share their ideas, their sort of good practice, and we're hoping to use the forums to sort of collate that over a period of time. And we really want people to help us sort of refine this programme as it goes on, so it won't stay sort of as it is today. As we hear from people, as we hear from people's ideas, we will build upon that. And in the spirit of sort of improvement methodology, as I say, we will really keep updating our futures platform to make sure people see that best practice as it comes through. Next slide, please. So what's covered today? The learning from, we're going to share the learning what we have done from providing our intensive support to support community-based mental health services to improve. We've also got Matt Noonan from the Elective Intensive Support Team, who's going to share his learning from the Elective Recovery programme. As I've touched on, we will then have a brief introduction to the 7 modules that we're running over the next couple of months. And then at the very end, a colleague will talk through how you can access those resources and just remind people of the next dates. Next slide, please. I think it was just important as well just to remind people what elective mental health care is, just to go back to basics to make sure we're all on the same page. So what do we mean by elective care in mental health? So care that is planned in advance, obviously is known as elective care. It involves specialist clinical care, generally following a referral from a GP or community health professional. In mental health services, this encompasses most community-based services apart from crisis. Next slide, please. So why does mental health need elective recovery support? We know that other sort of our acute colleagues have got elective recovery programs in place. Many community teams and both adult and adult children we've recognised that even before COVID, we'd started to see increases in longer waiting times, wider variation in our service offers and our outcomes for our patients. Unwanted variation is a major obstacle for all of us in achieving our safe, effective patient care. And I think we all recognise that variation just doesn't happen at a regional level, but it happens at a provider level as well, even right down into departments and team levels, and in some cases even between individual clinicians. The variation between what our patients receive is so large that even when we started the 5-year forward view, we said it was impossible to say that all patients could be receiving good care. We all know that there are problems in elective mental health services lead to poorer outcomes and experiences for the population we serve. And we also know, and we are starting to see this huge increase in demand in our crisis and inpatient services. Next slide, please. So what is this programme of support for mental health elective recovery? So we've developed this programme looking at really over sort of based on the last six years of our diagnostic reviews and into early intervention in psychosis, children and young people's mental health services, our IAPT work. It's been built on our on-site intensive assessments of each of the 4-week pilot sites. And then we've established methodologies for elective care programs, including post-COVID. So we're hoping that by using these resources, it will support systems to use quality improvement interventions that will help contribute to optimising operational delivery of community-based mental health services post-COVID. As I've said at the beginning, the programme does include resources to improve quality experience and outcomes, and we'll do this through improving access, waiting times, utilisation of clinical resources and fidelity to best practice. And when we talk about that best practice there, we're very keen to talk about best practice that's transferable. We recognise that we have pockets of best practice and it works in one location, but what we're really interested in is about how we put the building blocks in to be able to transfer that to another service and make sure all of that is transferable, and that's some of the conversation that we want to generate. And we're hoping that these modules and these tools will then help support mental health systems to track their activity, identify any issues, and undertake targeted sort of data informed improvement work over a period of time. So that's the programme in summary. I'm now going to hand over to Matt Noonan from the elective care team, who's just going to talk you through some of the work that they've been doing. Thank you.
Thanks, Paul. Morning, everybody. My name is Matthew Noonan. I work for the elective care improvement support team as part of NHS England. We're very similar in makeup with the mental health team in terms of the people that have worked out operationally in the NHS and elective care for a number of years. So we are heavily involved in sort of the recovery approach around elective care, which actually sort of started during the pandemic, actually, where there was a big focus on clinical prioritisation to really get an understanding of where risk lay within elective care and to understand the challenges that certain groups of patients were facing to be seen. It focused on the sort of length of wait in both referral to treatment and non-referral to treatment. So referral to treatment is our sort of headline waiting measure, but obviously a significant proportion of people who are on waiting lists in elective hospitals are not on that headline measure. They have had a treatment and now in sort of follow-up or being looked after differently. So it was focusing on both aspects of this, not just the headline waiting list measure, which obviously at the moment we've got incredibly long waits for. We've also seen the sort of background that's happened over the last few years is there's been a real loss of the sort of the waiting list management skills, largely because people have not been focusing for obvious reasons. And a lot of new staff have joined obviously in the last 2 or 3 years, and their sort of induction processes haven't necessarily picked this kind of stuff up. And actually, historically, we've been pretty poor at sort of building the capability of our certainly our operational management teams. I can include myself in that. If I look at my own career, you know, that we haven't sort of invested in training people on the sort of skill around waiting list management. So there's been a sort of clear approach, I guess, around elective care recovery, and it is very focused on the stage waiting time, so stage of treatment and total waiting time. So we are in the process of trying to reduce our waiting times from 2 years now down to 18 months by the end of March, then further iterations down to a year, and I'm sure going past 2025 it will go further back down, hopefully towards the 18-week level. But within that, there's also some stage of treatment markers that people are interested in, certainly within cancer. There are measures around diagnosing people as well as treating them, and there's a big focus at the moment on sort of wait for first appointment for all aspects of elective care, because we know again that people have waited a long time to be seen in the first place, which also presents an element of clinical risk while they're sort of sitting there without someone having actually seen them, examined them, and understand what their problems are. It then obviously makes trying to prioritise those patients more difficult if you have very little to go on. So there's been an approach around for that focus, and there's been an approach around sort of upskilling staff and retraining people on some of the basics or fundamentals, is probably a better word, on elective care. So just go to the next slide, please, Justin. So the sort of, for us, we focus on sort of 4 sort of the pillars of waiting list management. So there's a focus on designing pathways of care, so making sure people are utilising some of the good practice pathways that have existed for some time, especially again with things like cancer. There are some work streams nationally on sort of ophthalmology, orthopaedics, cardiology that are focusing very much on a holistic pathway of care, so not just in secondary care, but from community into secondary care and then out again as well, which is really important. So making sure that the steps are clear. Again, it's not a sort of one size fits all approach, but sort of broadly speaking, so people know the pathway they're trying to deliver, because you need to have that, or we find that we need to have that in elective care to be really clear on the next stages, which moving into, okay, well, if you know what you're trying to deliver, do you have the relevant capacity in place in the right places to meet the demand that's coming through those streams? So we're doing a lot of work on demand and capacity training with people so that they can be clear at each thing they're trying to do, that they've got enough capacity. And so you know it definitely helps to have the pathways in there, but you can obviously also do these things in isolation. And I'm sure I know some of the content that the team will be discussing going forward in these modules will cover some of that for you guys. The other focus that we're doing a lot of work with organisations on, and it's probably one of the most important things, is around the governance. So again, when I looked operationally, you know, governance wasn't maybe the strongest suit for lots of people, and understanding why it's important to have strong governance around elective care and the recovery effort. But having now sat on some of the other side and see the impact of when it's not in place, it's crucial to get this right. So we're doing a lot with people to reinstate the governance. So lots of places again have lost some of the meeting structures, the forums, the understanding about why people will need to attend those things, what they need to do in preparation, how to sort of forward look against services, because of the fact that they've been dealing with COVID or were dealing with COVID for a significant amount of time. And even now, when they're focused much more back on elective care, it's often very focused on just the people at the end of the pathway and not thinking holistically about the whole pathway. So doing a lot of work with people around how they set up their meeting structures, how they monitor their services going forward, using things like 642 approaches, which is a thing that's sort of started in theatres, but actually has applicability to any service that needs to look forward and make sure that they are set up effectively. So yeah, doing a lot of work around that, and we're finding that it's so crucial. Really, you know, you get it right, you've got the ability to proactively manage issues, identify risk, you know, coordinate those responses, so you can be as proactive and sometimes as reactive as possible. You know, sometimes you can't always be proactive, but it's important to be able to be in a position that you can react as quickly as possible when things change, which they do have a habit of doing. And then finally, all of that, I guess, underpinned around sort of clear reports. So PTLs, patient tracking lists, is obviously a big thing to be really clear. We're doing a lot of work on making sure people, their reports are accurate, that they're capturing all their patients. We do often find that people are missed, and therefore they can't easily be managed if you can't see them. And doing a lot of work with people about how you can use other things, so you know, utilisation, productivity, in using good data to help underpin this. So those are broadly the headline sort of things that we're doing in elective care and focusing on, and you know, they all work in conjunction. I think as you go through the day and the rest of the sort of offer from the team, that they'll be picking up a lot of very similar themes. And I hope that we can sort of maybe pick up some ideas from you guys as you work through some of the challenges that you face, because I think there's a lot of cross-pollination potential here. So that's for me. Yeah, again, welcome to taking any questions towards the end of the session. But I think I'm handing over to Francis now from the mental health team.
Hello, hi, good morning, everyone. My name is Francis Ibonwoke. I have been working in the mental health improvement and system support team for the last 6 years, and my colleagues and I have developed the mental health elective recovery modules, and I have led on the development of the commissioning module. Prior to this role, I worked in the national performance team when the first waiting time standards for mental health came into force. And in the past, I've done various roles in pharmacy, commissioning, and service improvement. And yeah, in terms of our 7 modules, it really sort of boils down to 3 things, really. You've got before you the driver diagram that basically sets out the nuts and bolts of what we'll be sharing with you in the upcoming webinars in the next few months. And it sets out essentially the key message is this, that a few key things done very well can significantly improve access, reduce waits, and achieve good outcomes for many. And that's why we're all here, and that's why we do what we're doing. So number one, it's about having a clear set of standards and expectations from the commissioning perspective. It is about having those standards in place to achieve end-to-end commissioning for a system designed to have no service gaps and no wrong doors. And at the provider end, it's about each provider having clearly defined offer and service scope that has been developed by partners. Number two, it's about achieving capacity and demand balance, having a system that can quantify its capacity, it's capable of meeting the demand or at least being clear about the gaps. And thirdly, proactively managing pathways, being able to proactively manage from a clear point of entry to a point of exit. And we will show you over the next few weeks and months the tools and processes that can help you do that. And so today, what we're doing is providing you with a taster of what is to come in each of these modules. Next slide, please. So hopefully, as we go through the webinars over the next weeks and months, you'll be inspired, we hope, to have a go at implementing some of the tools and approaches as relevant to your particular context. But what we want to do here is flag the importance of taking a structured approach to quality improvement, a structured data-driven approach to tracking the difference that these tools are making. And there are any number of quality improvement tools out there. No one is superior to the other. Just choose one. But essentially, you will find it's about being clear. These tools are, really encouraging to be clear about the goals you wish to achieve, identifying where you anticipate the impacts will be, and then measuring it through small tests of change that eventually can be scaled up in one pathway in one area at a time. And there's certainly lots of resources out there to help you do that. And certainly our futures page has links to quality improvement resources that you can use. So now we're about to come into the commissioning module. Next slide, please. And what I really do want to start off by saying is that this module, which will be in February, is not intended to teach commissioning colleagues how to commission. Rather, it's the product of our observations working with systems over the last 6 years to raise awareness of the opportunities to optimize mental health delivery through the commissioning processes, as we've observed a number of unintended consequences that can occur. So today, and starting off in the areas of commissioning, of strategy and culture, we will explore some of our observations through these lenses, strategy and culture, as to what the unintended consequences are, some of the barriers that we see. So strategy and culture we have chosen today because these are absolutely foundational in terms of delivery. It is about setting the direction of travel in terms of strategy and empowering delivery, on the other hand, with culture. And as you see here, systems that are struggling with delivery from our observations tend to struggle with some of these issues here in the bullets that you see. Firstly, a limited understanding of population need or expected demand, which in turn limits investment decisions and workforce planning. We also know that some population groups do not have equitable access and good outcomes, and therefore you need a sort of targeted and creative approach. Often commissioning can be piecemeal and reactionary, so you don't achieve that end-to-end commissioning to support the full spectrum of need, and then people fall in between the gaps or are held in services inappropriately. And as Matt was referring to earlier, where system governance is not sufficiently robust and is not coordinating and driving transformational work, what can happen is you have a sort of a poor visibility of risks that basically impairs progress. Ineffective system partnership working and communication makes it hard to achieve a seamless and coordinated pathway and therefore mental health system. And we've also seen particularly disabling impasse that can result when all partners don't have a shared understanding of investment across all parties. Another scenario that can arise is a lack of clarity around performance expectations, where the proportion, for example, proportion of activity for access standards is not attributed to each provider, which means no one can be held to account for the gap in delivery, and you can't effectively plan increases. On the issue of KPIs in the last bullet, there is something about KPIs being sensitive to the actual system needs. Now, you do need a mix of process and outcome measures, not one or the other, but ideally both, so that you can have sort of visibility as to what to improve. So, for example, we do have quite a few access standards in mental health, and where there isn't waiting time standards, it's important to have those contextual measures around, for example, in pathway weights, so that you can kind of see where the blocks are to flow, and certainly, the detrimental impact of, long waits in pathways has been a bit of a theme that the CQC has looked at. So on the issue of culture and involvement, what I want to say very briefly about culture, and I spoke about the importance of culture, is for example, the ways in which the variability in partnership working, and in some areas we've had observations of sort of limited use of voluntary sector partners for whatever reason. It's important to engage staff, in organisations at all levels in the transformation that needs to happen. We've also seen the adversarial approaches that have been taken, for example, in performance management approaches, and that hasn't engendered the honest conversations that are required. And so it's been sort of a blame culture rather than a learning culture, and that we've seen has impeded progress. In terms of involvement and participation from the angle of family and patients, that's really important, and it's important not to do it in a tokenistic way, but bringing them right from the beginning to sort of as an opportunity to redefine what does add value, and it can be surprising what people come out with. So I guess sort of that's a whistle stop tour in terms of the observations that we've had, some of the observations that we've had over the past years. Next slide, please. And in this cheese wheel here that you can see, we've grouped the common issues that we believe commissioning processes can influence into 4 key themes, which are represented in these quadrants here. We have developed a checklist of things to think about to address these issues, which we'll be exploring in the Optimising Mental Health Commissioning module in February. And it is intended that the checklist will enable you, commissioning colleagues, to be able to assess your current position in each of the 4 areas in regard to, for example, starting in the top left-hand quadrant, in regard to developing a robust plan to meet the demands in your system, developing an infrastructure that enables the delivery of the plan, optimizing delivery, and then finally putting in place robust review processes to oversee this. We believe also that the checklist will provide you with insights on the questions to ask as commissioners in your conversations with the provider. And on this point, I would encourage commissioning colleagues very much to attend the sessions for the other 6 modules, because that will really give you helpful insight as to best practice operational processes. So my colleagues and I are really looking forward to welcome you onto the module and learning together. We definitely want you to actively participate and join in discussion, and you'll be networking with similar colleagues and hopefully share tips and approaches with each other on what you have done or how you've addressed certain wicked problems in your various contexts. So now I will hand over to my colleague Sarah.
Thank you, Francis, and hello everyone. My name is Sarah Brennan. I'm a registered mental health nurse and improvement advisor with the Mental Health Improvement System support team, and I've worked with the team for the past 6 years. Before working with the team, I've worked in provider organisations for 20 years and have held several senior operational and governance roles. I've led on the development of the Access and Weights module and the development of its associated products. So today, I just wanted us to start to think about some of the drivers for producing this module. Across most of the country, there are significant gaps in the way that patients spend waiting. There are significant gaps in the way that the time patients spend waiting for treatment is monitored, reported and responded to. And it could be seen that there are a number of common factors contributing to this. Which would include issues such as being unwarranted variation in the policy and actual practice for access to treatment between services, differences in the understanding across systems about what national standards may be for accessing assessment and treatment, limitations in the use of locally determined waiting time standards and the use of monitoring tools such as patient tracking lists. There can be differences in understanding of what constitutes a sustainable waiting list, therefore impacting on effectiveness in forecasting and planning, for example, and limited processes for responding to waits exceeding standards and variance in actual oversight, particularly in inpatient in pathway waits. Next slide. Can I have the next slide, please? With this in mind, the Access Policy webinar focuses on the core principles of why it is important to have a comprehensive policy, and we'll look at the purpose and function of a good access policy. It is intended that the webinar will take into consideration different user perspectives, including staff, patients and carers, and other key stakeholders from across the system. The purpose of having an access policy is to state the arrangements for the management of waiting lists and to ensure patients receive timely, equitable access to treatment in line with the national and local access standards and the NHS Constitution. It should include clear guidelines and procedures to ensure that waiting lists are managed effectively and a high quality of services maintained. We know that people with mental health conditions who are seen more quickly have better outcomes than those with long treatment delays. Whilst access policies in acute and hospital services are widely recognised as key to providing guidance on referral, treatment and waiting time management, they are used less frequently within the mental health sector, with the mental health sector often having operational policies at a specific service level instead. The reason for these differences is unclear, but it could be assumed that because there has been less focus on the 18-week referral to treatment standard, for example, and there are fewer national waiting standards in mental health, it makes the need for having an access policy less obvious. However, having an overarching access policy which provides guidance on access and waits across all services and supports the use of consistent processes for managing access, referrals, appointments and discharge pathways is very much needed in terms of supporting timely, equitable access to care and treatment across all services, and not just for those where national standards apply. The webinar, which is going to take place in January, will take the audience through the key principles of what should be in an access policy, who should be included in developing the policy, and what critical factors for success are. This will extend to include the importance of review and evaluation of effectiveness of an access policy. So, for example, it needs to be usable, user-friendly and have impact. So key review and evaluation questions could be, have services had have services being accessed equitably based on need, and is access to all services being managed in a clinically effective and timely way? And how would we know this? So during the webinar, we will share with you and talk through an improvement tool checklist that can be used to support providers and stakeholders to develop comprehensive, usable policies. The tool is not meant to be exhaustive or specifically prescriptive, but it is intended to provide users with a framework to support developing a good access policy, which supports the principles of timely and effective access to care. Thank you. So on that, I'm now going to hand over to my colleague, Michael. Over to you, Michael.
Thanks, Sarah. Good morning. My name is Michael Watson. I've been a member of the team for 7 years, and prior to that, I spent about 5 years working in the elective care and cancer intensive support team, along with Matt, who spoke to you earlier. So the first module I'm here to talk to you about today is patient tracking. It's interesting that someone actually asked a question in the chat about what PTL stands for when Matt mentioned it earlier. And I think it's fair to say there's generally quite a lot of kind of jargon and confusion and general lack of clarity when it comes to patient tracking. But for the record, PTL stands for Patient Tracking List, and that can refer to a list of patients, or it can refer to the meeting in which the patients are discussed. It can refer to the process by which people are tracked. It's generally used as kind of shorthand for keeping an oversight and an eye on waiting lists and people waiting. In fact, at one point in my career, I laboured under the title of patient tracking manager, I think, for a while. Fundamentally, though, patient tracking is about who's waiting, what it is they're waiting for, and when it is that they need to be seen, and then the associated informatics and governance to support that. So the module that we've presented on patient tracking on our Futures site and the webinar coming up in a couple of months' time, we'll talk about how you can develop a PTL list, a patient tracking list, an actual list of people, but also what a dashboard kind of showing summary of that and then highlighting key hotspots might look like. We'll talk about some of the governance processes that you need to have around that, both for proactive management, so making sure that people can move forward and get brought forward so they don't wait too long. Clear line of sight, so the right people are aware of where problems might be arising, and how you can escalate clearly so that those who are trying to resolve the situation, if they're unable to, know who to go to next to get things done. So the emphasis of patient tracking really is not about knowing how long people waited in the past, but about how long people are going to wait in the future, and therefore what you can do about it to make them wait less time. However, we acknowledge that obviously, particularly at the moment, in mental health, a lot of people do wait longer than we'd like them to. So we've got some information in the module also about clinical harm reviews. They're looking both at individual patients and the groups of people to assess whether or not any harm has come to them as a result of waiting longer than you'd like. And we also look at thematic breach analysis. So that's looking at what's gone wrong in the past, trying to group those up into themes, trying to learn from that, and trying to make things work differently in the future so that it doesn't happen again. So on the Futures site, and also what we'll discuss in the forthcoming webinar, we've got a simple checklist so you can do a self-assessment of your PTL process. We've got some templates about what a meeting agenda might look like, terms of reference, who should be there, those sorts of things, how the meeting might run. And we've also got some specific documents, one about thematic breach analysis and one about clinical harm reviews. That's it for me for now. So I'll hand over now to my colleague, Nick. Thanks.
Morning, I'm Nick Kitcham. I'm an improvement advisor with the team. I've been with the team for 6 years, although I've recently spent a year on a secondment with a mental health provider. And before joining the team, I worked for 10 years in the acute sector in various service improvement and program management roles. So following on from the module on patient tracking and also linked to another module we have on optimizing capacity, it's really important for services to have a good understanding of backlog management, which is a really important component of demand and capacity planning, but we find it's often either overlooked or misunderstood. So this module will explain how a backlog and a waiting list are two different things, and it will provide you with a tool to be able to calculate what we consider the sustainable waiting list size for any service. So that's the number of people you can have waiting and effectively and efficiently utilize your slots, but also see people in a timely way. If you do have a backlog, which is too many people waiting above the sustainable waiting list size, then we'll talk through some of the strategies that are available to help you manage that situation and recover to a better position. Next slide, please. So moving on to models of care and pathway maps, and this module builds on a lot of the points that Francis was making around commissioning and the fact that service provision can become over time or be inherently fragmented and not comprehensive in terms of the service offer. And this is often a result of inadequate processes for actually mapping out what the pathways are and being clear to everyone involved in providing services and also accessing services as to what the service offer is. There's also frequently a lack of specificity over the offer in terms of what the actual treatments are for given diagnoses and the expected duration of treatment for people accessing pathways. So next slide, please. And another major aspect of this is the use of routine outcome measures. In some of the best services we've seen that have had really strong feedback, positive feedback from service users. There's a very good culture and use of outcome measures, but we know that outside of IAP services, this is still fairly patchy within mental health community services, with areas of good practice and areas which are relatively underdeveloped. But the use of outcome measures is important in terms of guiding treatment, but also informing service improvement, both locally and nationally. And we know there are some specific barriers to delivering this. They may be practical, technical barriers, such as the EPR systems or outcome measures, how they're captured electronically, not being very user-friendly to clinicians or to patients. But it also can signify some issues with leadership and the culture of the organisation. So next slide, please. Part of our offer related to models of care is on pathway maps. And the basic premise of this module is that although pathways can be very complex within community mental health systems, they shouldn't be confusing. There should be a clarity of the offer, again, both for practitioners and agencies involved in delivering the care, but also for people accessing them. So the module tells you what is a good approach to developing a pathway map, a clear pathway map that people can understand and reference, and what should be included in that pathway map. And then when you do have a good pathway map in place, how you can use that to guide service improvement across a whole range of domains, from patient experience and quality and outcomes through to productivity and the use of data and information. So the module has a preparation and self-assessment checklist to let you get an idea of where you stand in the spectrum of pathway mapping, sophistication or comprehensiveness within your systems and processes. And there's also an accompanying Excel tool which allows you to plug in some real-world data from your pathways to highlight in a visual way where there may be issues or where the care and the timeliness of the pathways doesn't align with the aspiration to delivering timely care. So that's a couple of the modules which I say are linked very closely to patient tracking and optimizing capacity, and I'll now pass you back to Michael.
Thanks, Nick. So hello again, everybody. Now I'll talk to you a bit about another one of the modules of our program about optimizing capacity. So first of all, just some of the kind of lessons that we've learned from our 6-7 years as a team working with dozens of mental health providers and mental health systems in terms of job planning, workforce and productivity. So it's easy for us to kind of dwell on the negatives. As an improvement team, we often see systems which need support, but obviously every negative is also a positive where other people are doing things really well. And so the idealized model that I'd like to describe is effectively the kind of flip side of where we've seen things not working as well as they could do. So effectively, what we're trying to describe in our modules is individual clinicians have job plans. Those job plans clearly articulate what it is that they're expected to do, what they're not expected to do, when they're expected to do it, and how often they're expected to do it. And that gives power both to team managers in terms of having clear expectations of members of the team, but it also gives power to team members in terms of being able to be clear about what they can and can't do and what they are and are not able to accept onto their workload. And what we've seen in the past is where people haven't had these job plans in place, it's then made it difficult for managers to understand the capacity of their teams, because if you don't know how much activity people are able to carry out, then you don't know how much that adds up to as a service, and you don't know how much you're able to deliver of particular interventions. And if you don't know how much you're able to deliver, you don't know whether or not you're able to meet the needs of your population. And if you don't know how much you've got now, you don't know how much your gap is to what you need for the future. So it makes workforce planning also very difficult. So what we've seen in systems that are struggling is that workforce planning and recruitment is very challenging, because it's difficult to articulate what's needed, how much of it's needed, what the capabilities are that people are trying to recruit to. Similarly, when we're trying to kind of plan for the future in terms of increases in demand or changes in population health, for example, around the changes we saw as a result of COVID, it's very difficult to plan for the future, because whilst you might be able to have a stab at predicting what demand might be for the future, or you might know that you've got more demand now than you had in the past, if you're not able to clearly understand what your current capacity is, because people don't have accurate job plans, then it's very difficult to say whether or not you've got enough capacity and or how much capacity you need. Similarly, in terms of productivity, we've seen that as a result of the lack of job planning outside of non-medical roles, outside of medical roles, I beg your pardon, there's a lack of clarity then in terms of what expectations are, as I said. So where people don't know what their expectations are and where we don't have accurate activity measurement, then it's difficult to say whether or not people are delivering what they're expected to do. And this can cut both ways. It's common for people to perceive that this might be a way of kind of beating people up and trying to get more activity out of people. But what we found in systems that are under pressure is actually it's just as common that people are overworking, in effect, and seeing more people than the expectation, as it is that they're seeing people under the expectation. So having clarity about the job plan and having clear activity reporting so that you can then compare the two and make sure the two are in alignment is a key kind of tool in the running of an effective service, both in terms of maximising capacity in your service, but also in terms of freeing up more time for people to care for patients and trying to reduce administrative barriers that might be stopping people from seeing patients. Next slide, please. So in our optimising capacity module and in the accompanying material on our future site, we talk about how to use job plans to understand clinical capacity. And you'll see the nasty little picture on the right there, giving an example of what we mean by a kind of detailed, specific job plan, describing what people's weeks look like, describing the interventions that they're doing, describing the patient-facing activity they're undertaking, and describing the non-patient facing activity that they're doing as well. We'll talk about how to respond in that variance that I described between actual activity delivered compared to the plan as laid out in the job plans. It's important to underline that there will be variance. This isn't about kind of beating people up. This is about saying it's not always going to go according to plan. Can we understand why it's not going according to plan? Is there something we can do to help you so that it goes closer to the plan for next time? And we'll also talk about a kind of more structured approach in terms of using that job plan to add up all the individual job plans in a service or in a team to say this is how much capacity we've got as a team. This is how much capacity we've got to deliver these specific interventions. And this is how much activity we've got to deliver this specific part of the pathway, as Nick described before. And we'll also talk about using quality improvement approaches to improve productivity. So, for example, what I talked about in terms of comparing that variance, understanding where there might be things that we can do better to increase productivity. And by productivity, we don't mean people working harder, we mean people working better and clinical people spending more of their time doing clinical work. As well as that content which we described in the module and on the website, we've also got an optimising capacity self-assessment checklist, as with some of the other modules. And we've also got a team capacity modelling tool, which we'll talk about in the forthcoming webinar, which we've developed just a kind of simple way of taking all those job plans and adding them up and getting an understanding of what the realistic capacity is that you've got in your team. That's it from me today. Now I'll hand over to my colleague Simon. Thank you.
Thank you, Michael. Good morning, everybody. My name is Simon Bristow. I'm a system improvement advisor in the team and a mental health nurse by trade. Prior to joining the team 3 years ago, I worked in provider trust across various different clinical, operational and quality governance orientated roles. And since joining the team, I've led on the development of the mental health demand forecasting resources that we produced during COVID. I've worked supporting organisations in the recovery support programme and have led on the development of the patient flow module, which I'm going to talk to you about today. The sort of genesis of this comes from the kind of perennial issue where in a time resource constrained system with limited oversight over patient flow, the attention often becomes focused on managing the front door and clinical crises. And then as waiting lists and caseloads grow, that is compounded and creates a self-perpetuating cycle whereby clinical capacity is diverted to manage what's happening at the front door at the expense of reducing the time, the clinical and managerial time to prepare for effective transitions out of the service, and the ability of the service to respond if someone needs stepping up into a service is reduced, which often leads to, in collective, leads to a reduction of oversight over issues that are occurring at the back door of the service. So you end up with patients being held onto for monitoring as a result of anxiety amongst all parties that are involved, that they'd be unable to get back into services should they relapse, and the data isn't available usually within the teams to monitor where we're at with that. So this collectively produces a therapeutic drift in treatment, clinical risks, unequal treatment opportunities for people who don't meet risk thresholds, and detrimental impact on staff and patient experience. So the management approaches that are within the improving patient flow module can essentially be summarized as setting out local standards for how patient flow is overseen and managed, agreeing a set of standardized coding for reporting on where there are delays in patient flow through the system. So generating and using data to establish whether the local standards and treatment goals that have been set for patients are being met, and then exploring the reasons for the divergence between the plan and the actual position within your operational and quality governance structures. And as Michael said, things don't happen in accordance with expectations. There will be variance, and I think when you look at your sort of data and within the pathways, and you're looking at best practice guidelines, it's possible to make an estimation of what the expected usual range of treatment duration would be. And then obviously people, don't always fit into that, but we need to think about, well, if people aren't getting better in our service, then what are we going to do about it? How are we assured that we are meeting people's needs, and how can we, what further support do we need to provide to people in order to, assure that they're getting the optimal treatment and are not sort of, drifting within the service. And finally, when you've generated all of this data, using quality improvement approaches to address the issues that are identified. So there is usually a plethora of different reasons why things aren't happening, and people aren't getting better, or people aren't moving through the service. So there may be clinical quality improvement programs that come out of this. There may be the identification of treatment gaps is a common issue where services don't feel that there is a service that somebody could step down to, for example, is a thing that we've heard very often. So there's different kind of governance routes, and different groups of stakeholders would be required to be mobilized to address some of the issues that starting to report on this stuff generates. So in terms of the approaches, there is case management supervision on a regular basis in between each session to look at patients' progress towards their recovery goals and against the pathway expectations. There is setting clear treatment goals at the beginning of treatment with patients. So the formulation step, agreeing an expected duration of treatment and what the purpose of the treatment is, and how you will know when it's finished. So what are the criteria that you're trying to achieve with the treatment, and how will you know when that person is ready for transfer or discharge? There is having oversight over transfers and discharges out of the service, alongside the oversight that you have over treatment starts. So that would be entry into the service, as well as there's often gaps in oversight over internal waits. So for example, if you take traditional community mental health team models, for example, people would come in and be allocated to a care coordinator, and if there was a waiting time monitoring system. At that point, their waiting time monitoring would stop, and then they may be identified as needing family therapy, for example, and then there may be a waiting list of 6 to 12 months for family therapy in some instances, but that isn't necessarily reported on within the governance system, and may exist as a Excel spreadsheet in a manager's desktop or a piece of paper in a secretary's drawer somewhere, and there isn't oversight over this internal waiting time for a treatment that has been identified as being appropriate for that patient, and there's all sorts of issues that then generates. And finally, extended treatment reviews. So thinking about how, as a multidisciplinary team, do we respond when people don't meet the expectations that the service has got and that has been agreed with the patient about what it is that they will receive, how long they'll receive it for, and what we expect the outcomes to be. So it's not uncommon within services to see, say, 5% of patients taking up nearly 50% of appointment slots due to very long episodes of care. And lots of concerns is the patients that tend to be in services for a very long, community services for a very long time, are generally there because they're quite unwell and have quite complicated difficulties and have multiple social, medical, psychiatric and other difficulties, and there is getting a lot of input from a lot of different people. So if there are patients in our service that require really high levels of care and high levels of resources, then we have a responsibility to ensure that we have adequate oversight over what those patients are getting and why, and whether we are doing everything that we can and should be doing in order to help them on their recovery journey. So we've produced some there's guidance around this and some tools to help support with setting up some of these systems for looking at what is happening, where and to whom and for how long, including some example case management supervision coding, some example coding that you might want to use for extended treatment reviews, and a patient flow checklist to look at all of the different aspects of how this should be monitored. And we absolutely don't have a one-size-fits-all approach to this. This really has to be locally determined in line with the local expectations, the clinical expectations for the particular pathway. We don't believe in arbitrary capping of session numbers and whatnot. This has got to be decided in line with the evidence. And as Michael said, it's not about sort of performance managing something of it has to happen within whatever time frame, but it's about what are we doing about assuring ourselves that that all variation in our pathway is warranted rather than unwarranted. Can I have the next slide, please? So I wanted to, at this point, we've talked through all 7 of the modules. I'm going to change tack slightly and talk a bit first about a plug for our colleagues in the NHS England demand and capacity team. So the stuff that we've talked about today will give you the ability to undertake demand and capacity modelling. One of the the real challenges that people have when they decide that they want to do demand and capacity modelling is that they don't necessarily have oversight over the data that they need in order to populate the models with in a defensible way. So the caseload model was specifically designed and I believe co-produced between the D&C team and colleagues in CNTW to look at sort of adult CMHT type services. So it was also applicable for various other different types of services in mental health provision. But obviously you need data on the activity of what is coming into the service and what is happening within the service in terms of your clinical capacity. So the modules that we've talked to you today will give you the data that you need in order to work those. And the team is excellent, the demand and capacity team, and they offer hands-on support, coaching support, advice, guidance, etc. in terms of using the models. So if you have desire to make contact with them, they've got a futures platform, and we can also facilitate conversations with them as well because we work very closely with them. And obviously there's a lot of synergy and handoff in between the work that we've talked to you about today and the work that they do with organisations also. Could I have the next slide, please, Joyce? So a cross-cutting theme from all of the work that we've done in the diagnostics and the 4-week wait pilots and various other things recovery support also is that there is huge benefits to be realised from having digitally enabled solutions to report on these things: access, waiting times, activity at different steps in the pathway, outcomes, patient flow, etc. But there are huge and multiple barriers to realising these in trusts across the country. First and foremost being that the investment and maturity in our data and informatics systems is significantly behind the acute sector. You know, so we talked earlier, the sort of use of things like patient tracking lists, etc., and the systems to report on those within, you know, ward to board governance systems across the organisation is a long-standing thing in the acute sector. We are sort of in the foothills of in mental health. And there's huge variability in terms of the practice around the use, availability and use of data, both patient needs, patient status, clinical activity and outcomes, etc. We see a lot of, especially around the oversight over who is getting what from whom and for how long, that really varies significantly and is often not really reported in the governance systems outside of a sort of team level. Some of our electronic patient record systems are not configured to be automatically assistive in tracking waits, especially in-pathway waits, which has been a barrier for a number of organisations and requires various different sort of fixes that sort of sit alongside the electronic patient record system. And there are long-standing and well-known duplicate entry and interoperability issues across different electronic patient record systems, both where there are multiple providers and where we're providing joint health and social care interventions services from mental health trusts also. And what we often see, for example, is, you know, in terms of patient recorded routine outcome measures, we will often see things being completed in triplicate where, you know, there's no mobile app for doing something with the patient, so a staff member has to do it on paper, and then they have to put it in the EPR in order to feed the KPI reporting, but the EPR doesn't put out any graphs or data that can be shared with the patient so that they can track progress through their treatment. So then the staff have to then triplicate entry into an Excel spreadsheet in order to produce a graph that they can then show to the patient, say this is how you know, your routine outcome measures are changing over time, which is obviously a suboptimal way of doing it and frustrating for the staff that are involved. So if you want to do this work, we would really strongly recommend that you think about ensuring that there's sufficient digital and informatics resource made available, and that's both in terms of any developmental work that's required around EPRs, electronic patient records, and also the building of the digital dashboards that we believe are very assistive in supporting clinicians and managers and providing that line of sight within the organisation. Could I have the next slide, please, Joycelyn? Thank you. And we've built all of these resources. They're all available for free now to all systems on the Future NHS platform. So please do register, go and have a look, see what you think. These are we've brought these out now to because they're quite clearly linked to the national ask around demand and capacity modelling for winter, in that, as we said earlier, some of the issues in elective care drive some of the crisis demand issues, and we're going to be, as Paul said, we're going to be refining them and testing them over a period of time. So please do give us feedback on those. We very much want this to be a partnership with people that are using them. So we're offering implementation support to all systems across the country, to all organisations. There's obviously this programme of national webinars that will talk about the content of them. And we're also offering free and bespoke coaching, consultation and support to all systems who want to use them, which is something that we've not done before and we've not had the ability to do before, and we're very excited to be able to do that. We provide additional sort of bespoke deployed into organisations for hands-on support where there are challenge systems who are under the recovery support programme, and that includes independent sector providers. And we offer support to regional teams in terms of building their capability for mental health improvement support, because that's variable across the country. And we are working closely with our colleagues in the model health system to continue to iteratively develop the metrics around quality and unwarranted variation there, so that we can try and bring together the learning from the deployment of this program with the developmental program for model health system. Can I have the next slide, please, Joycelyn? So if you do want to take up support from us, we would be very happy to work with you. We don't have any prioritization criteria other than that you want to undertake the work and are going to apply the resources and the political will to undertake it. To give an example of the sort of things that we'd be expecting to do within that relationship, it would be around coaching of implementation leads, coming to the key governance meetings, such as implementation program boards, checking and challenging your plans, and linking you up with possibly other colleagues in other organisations who are doing the same work, either at the same stage or further down the line, and support with developing individual localised approaches. So, you know, a lot of this is about designing and setting local standards and then managing activity against them. So you will need sub-program board, task and finish groups of clinical and operational leaders in order to do that, and we can provide some input and assistance into those. So if this all sounds familiar and the approaches that we've talked about sound useful, we'd recommend, if we may, that you have a look at the resources and tools on the website, have informal conversations with your colleagues around what you think your priorities would be, either a noise or a sort of SWOT analysis around what your barriers and enablers are and how and where this might complement and support existing programs. In the organisations that we're testing this with at the moment, I mean, these obviously align to the children and young people's mental health transformation programs and the adult community mental health transformation programs. So we are citing this work within the existing governance and oversight processes that they have for those programs. Have a think about what resources you would need in order to be able to give the dedicated time to allow this work to be done. A lot of the driver for this is that getting this stuff right in the first place reduces the amount of firefighting and sort of, you know, chaotic activity further down the line, but it does require the allocation of resources in order to do it. So that will be dedicated, expect that would be dedicated project resource of some degree, depending on the scale at which you wanted to do this, as well as the clinical and operational capacity that is required in order for people to get together to agree what they're going to do, how they're going to do it, what the standards are going to be, and design the reporting pathways, etc. So please do get in touch with us for an initial conversation about the support available, or to talk to any of those next steps that I've gone through there, if there's any questions that you have about those. Can I have the next slide, please? So just to specify, I suppose, if we are working with an organisation, the things that we ask them to do are to identify named leadership with accountability for delivering the change. So that's the sort of board level or nominated representative under that, to be the named person who is going to lead on the delivery of this. To allocate the project resources, and as I said, the sort of wider leadership capacity to deliver the change. It needs governance to support delivery, so a senior forum, reporting routes for line of sight and escalations, and a home for the design and delivery of the implementation plan. And then in terms of our sustainability and leaving something that's going to continue to exist once we've finished our work together, there would obviously need to be changes to organisational policies and the governance reporting systems to ensure the sustained change. And we want to work with you around conducting a sustainability assessment and developing a maintenance plan for after we leave. Can I have the next slide, please? So we are contactable via multiple routes. This is our direct email address, england.mhist@nhs. We've got a future NHS platform, and each NHS England region has an allocated link worker from the team. And you can contact your link worker directly via email. These will be hyperlinks when these slides are sent out after the session today. If you want to know anything more about us, we've also got biographies on our future NHS page as well. So again, I know we keep plugging this, but please do register on the platform, because that's where we host all of our resources, and we will be hosting the discussion forums and whatnot also. Can I have the next slide, please? There will obviously be this continued program, as I mentioned earlier, and there are links to the registrations that are in the beginning of the chat or Q&A section for this webinar. So please do register for those. And could I have the next slide, please? And the next slide, please. Thank you. So at this point, I'll say thank you very much for listening to me, and hand you back to Paul for the Q&A.
Thank you, Simon. Hopefully it's come back to me. So thank you, Simon, for that, and thank you for the helpful summary at the end of how to get in touch with people. And thank you to all the presenters today for taking the time to go through the modules. I hope that has given everybody a sort of a flavour of the programme over the next couple of months, and you can see sort of what type of activities and discussions you'll be able to get involved in around those subjects. So looking at the question and answers, we have got a bit of time left, so I'm just going to hand over to my colleague Sean just to say if there's any sort of summary questions, and he can then sort of direct them to the relevant person in the team. So over to you, Sean, if I can.
First question we've got, and it's from workforce perspective, staff shortages is a huge issue. Systems often rely on effective mutual aid. Do you have any insights on how to make it as effective as possible?
Who's that going over to, Sean?
Sarah.
Thank you. So we hand over to Sarah to answer that. Sorry.
Thank you, Sean. Sorry, I apologise. I was struggling to hear some of that. I think what I heard was there were talking about the huge staffing shortages and the issue of mutual aid and how to best work with mutual aid. Is that right? Amongst organisations. Right, yeah. Okay, thank you. I mean, I suppose system governance is really important, isn't it? And I think about having clear, agreed processes for escalation and how organisations really understand the system governance. And I think there will hopefully be opportunities as we move towards ICBs and ICSs, and particularly provider collaboratives, about looking at how that works. And just thinking about some of my experience when I was sort of redeployed during COVID, there were great sort of learning opportunities really for how mutual aid was used there. And I think it's about how then that's adopted into policy and procedures going forward. I don't know if any of my other colleagues have got any sort of observations they want to share that.
No? Okay, thank you, Sarah. Sean, is there any more sort of summary questions?
Yes, well, for Nick, would learning and insights about making time for improvement be included in any of the modules in the backdrop of current capacity and staffing problems?
Yeah, good question, and it's obviously a real challenge for people when as Simon mentioned, people are firefighting and just dealing with the day-to-day demands. I guess the answer is we don't directly address that in terms of we don't have any top tips or solutions, but essentially a large part of the modules and the basic premise of the whole program is that if you could do things more effectively, then inherently you build up more capacity with the resources you already have in the system. So it's about trying to avoid people doing things that they either don't need to be doing or shouldn't be doing in terms of wasted activity, and being able to do things more effectively and getting things right in the first instance. So that's really the premise for increasing the utilisation and capacity you get from the staffing you do have.
Can I drop in an additional point on that, if I may. Just, I guess there's a couple of different ways that you can cut this stuff up, and I suppose thinking about it in terms of if you were doing a workforce strategy, you'd want to start from thinking about what are the skills that we require and in what quantities, rather than thinking about who are the, how many nurses or how many doctors do we need, for example. And I think it's similar in terms of the design of some of this. So there are things that are going to need to be done by managers and clinicians. So, and senior clinicians. So thinking about, how the design of things. So what information do I need in order to manage X, Y, or Z? What information do I need in order to understand, what is happening clinically for a patient, for example? However, a lot of the sort of legwork within this is going to be, it doesn't have to be done by managers and senior clinicians. So there is a lot of work around electronic patient record development and building digital dashboards, for example, which is business informatics and whatever EPR developmental teams. There is a strong program management component to this, and we'd really recommend that there's dedicated project resource to this. So I think it's important to try and approach it from that position, which I'm sure is not news to anybody, and I'm sure was probably considered within the question, but just wanted to reiterate that.
Okay, for the next question, let's stay with you, Simon. How does the use of digital health technologies fit in with the mental health elective recovery programme?
Good question. I mean, I guess digital health technologies is a pretty broad thing. We within this program, what we have sort of focused on is what data do we need, who needs it, and how do we get it to them. So it's been largely orientated around what can we pull out of electronic patient records and put into a format, usually a sort of dashboard type format, to enable senior clinicians and managers, and then the line of sight up through the different levels of aggregation that are required in the governance groups to operate effectively, so that it's not being chucked out into spreadsheets that then somebody has to run into a chart or sort of put into a Word, export and put into a Word document so that it can go in a PDF pack, all that sort of stuff. It should be live, available and filterable information that's visible at different levels in accordance with whoever's looking at it and whatever their needs are for it. So there's, and trying to bring a sort of standardized approach to how we look at these things. So there's different, there may be different waiting time standards but within an organization, but there should be a standardized approach to managing waiting, and at the moment that's not necessarily the case. And it's the same with oversight over patient flow and where there are clinical pathways and where there aren't clinical pathways, etc. as well. So it's about trying to use digital tools to, one, give us some standardized ways of managing things that are configurable by local standards, and two, making sure that data is easily visible in a way that doesn't require manipulation of spreadsheets and copying and pasting into other documents, etc.
Okay, thank you. And we've just had a question in the chat that I've noticed as well, just about asking around sort of the work and how it needs sort of clear leadership and changes to organisational culture. I was just wondering if I could bring Frances in just to give her insights into that and her experience of working with some providers on these programmes.
Yeah, thank you very much, Paul. I think, yeah, absolutely. This is the heart of the matter, isn't it? Leadership and culture. And I think what I would say from my observation of working with systems, and I don't know whether other colleagues would agree, is very often people do not know what it is that they do and the impact that it can leave wider staff. We have worked with a range of organisations, and they have been at different spectrums, or different ends of the spectrum, I should say, of challenge. We've worked with very challenged organisations where there's been a lot of regulatory activity, and leaders are sort of responding, firefighting to all sorts of questions that they're being asked. And quite frankly, staff are sort of tired, jaded, unconnected to sort of like the purpose, the vision, etc., etc. And then we have sort of worked in other organizations where things are quieter, quote unquote, and calm, but there's sort of a disconnect. And I think for us in how we work, we very much are keen to take a multifaceted approach, if you like. So when we're working with organizations where we're providing targeted support, we will seek the views and perspectives of a number of various groups of staff. We will not just speak to one group of staff, if that makes sense. The leadership will have their perspective, staff will have their perspective, and we try to bring consensus in those perspectives together. And I think for us, it's underscoring what works and what doesn't in high performing organizations, and that's how we have sort of tackled it. But very often the awareness of the impact of various approaches or behaviors sometimes is people are not aware of what it is that they do, and the impact of it. And the first point, if you like, is that awareness. But I agree. I think with I don't know the name of the colleague. I agree that is really, really important, and it's part of our in the various tools that we've developed, whether it's the system maturity tool in our sort of work with children, young people's mental health systems, or in adult IAPT. Leadership and culture is something that we very much incorporate into our assessments, and indeed we sort of give feedback in terms of what would be helpful approaches going forward. At this point, I'd like to invite any of the colleagues who've been with me in such reviews, if they want to add additional comments and insights, that would be helpful. No.
No? Okay.
Looks like
All
I've covered it.
You've covered it. Thank you, Francis. Sean, is there any final questions as we come to the end of the session?
There's a couple more. Just pick one out. I'm not sure who this will go to, but on case studies, this case studies QI work in this area would be really helpful. A lot of time, sometimes in organisations, is spent on convincing clinical and non-clinical staff that this work is evidence-based. Also might in setting realistic timescales and expectations.
Okay, thank you, Sean. So as we've talked about through the programme, so just to, if people didn't hear that, I was just asking about sort of case studies and sort of pragmatic sort of things to be able to share with clinical colleagues, etc. As we've said at the start of this programme today, we really want to work with you to generate those discussions. We want to use our sort of Futures platform to the forum there to generate discussion, and we want to sort of work with organisations to build up those case studies going forward, those areas of best practice that we can then share on our website. And we really want to encourage people to do that. And as we said at the beginning today, we want to try to start generate those case studies that are transferable, so we know that they could be replicated elsewhere, or at least outline those building blocks about how they can be built elsewhere. In the background to this programme as well, we did write out to all trusts to ask for sort of, if you like, volunteers to work with us on some of these modules, and we had 4 or 5 trusts come forward to run through some of these modules with us as well. So we're also hoping to build up some case studies from that as well. So yes, absolutely, we're hoping that there will be case studies going forward, or sort of a practical sort of pointers, if you like, to demonstrate to clinical colleagues sort of the added value that this type of work does. But I think in summary, it does come back to Simon's point about actually we do need to go back to getting the fundamental sort of basics right in these programs to stop the firefighting further down the line. Is there any more questions after that, Sean, or are we? No.
There's one about PCNs.
Okay, I can't see that. What does that say?
Some PCNs see ARRS mental health workers as a GP type capacity relief rather than transformation to improve patient journeys and experience. What resources are there that could assist PCN process change in these cases?
Yeah, that's a good question. I'm not sure I'm fit to answer that. Does anybody have any insights into the new world of PCNs? I think that's something we will certainly I'll offer it out to anybody in a minute if anybody's got any more insights. But obviously, PCNs and the roles that they are utilising are new in some cases. I think sort of the overview of the modules would apply to any pathway. So I think we would have to look at those particular roles, that pathway, how they're using it to work with capacity or waiting lists, etc. And we would have to apply it in that way. But I'm not 100% sure it would work for our overall programme, but it's certainly something we can have a look at behind the scenes and see if there's something we can give as an example for that. Don't know if anybody wants to come in and add to that, or if that's okay.
I suppose it's just I was just responded to the colleague who put in something about the digital interventions in the pathways as well, and I suppose it's along the same lines really, is that these are what we've put in these resources are management approaches to how, you know, to bringing together the people, for example, to design a pathway. We've very much steered away from anything about what should be in the pathway, because they are, you know, that's not sort of within scope of what we were trying to do, and obviously would need to be locally determined, and obviously there's, you know, different levels of evidence and different levels of you know, kind of real world pragmatic experience in terms of models and whatnot for different different aspects of mental health service provision. But we've really focused on the how to rather than the what should be in.
Okay, thank you. Okay, so that was the final question, but if anybody does have any further questions, please log on to the Future site and propose your questions there in one of our forums. That'll generate sort of answers from colleagues in that network, and we'll also monitor that and chip in as appropriate as well. But I just wanted to again thank all the presenters today for introducing their modules, and more importantly, thank you for all the attendees for taking the time and interest to come along and hear about the programme, and I really hope that we see you on the future modules in the coming months. So thank you for all attending today.